Good morning, dear all. I'm very happy today to associate myself with Indian AFPAGUJCUN 2021. Today, very interesting topic given to me, social challenges in family practice, time for change. Next, friends, good enough is no longer good enough for today's family practice. It's improve it or lose it. Next, few challenges we family physicians are facing: assault on doctors, increased competition, infrastructure struggle, mixopathy, fewer number of new family physicians joining practice, communication skill, burnout, affordability or the cost of healthcare, geriatric population with multiple chronic diseases. Next, as a preamble, in current times, family practice faces significant challenges to fulfill its role in providing comprehensive care and integration with rest of the healthcare system. It must be easily accessible with evidence-based practice and affordable to every person that approaches the physician. Next, sir, you give me. So assault in India, patients visit doctors with the notion that family physicians will cure the ailment with 100% success rate. While putting such blind faith is not ill intention, the consequences of a negative outcome can be catastrophic both for the patient as well as for the doctor. Besides psychological trauma to the doctors, such incidences might include the mental harassment, disturbances to the hospital and clinical staff, destruction of the property, and disruption of the medical care to the community at large. Next, assault, the most important previous slide, previous one. In India, the patient visit doctor with the notion that family next. Yes, next. Fewer number of family physicians, fewer number of fresh graduates opting for family practice. While all the reasons for this observation are not clear, lack of financial incentives might be the main reason. Next, one of the main reasons is more and more postgraduate seats are available in medical colleges. Many students secure job in government, semi-government, other NGOs where they receive a handsome, lucrative salaries. Significant number of students are considering moving to foreign countries and very high cost of establishment. Next, setting up an appropriate infrastructure is a crucial problem nowadays family physicians are facing. Numerous hurdles must be crossed before establishing a new clinic. Price of the property is one of the factors, but along with it, purchases of medicine, equipment, recruitment of staff, loans and interest on loans, proper documentation, procedures and adherence to the local and state law all require significant initial investment. Next. So inflation, population, density, saturation, and other factors at urban centers have led to the cost of real estate to skyrocket. This phenomenon has discouraging young doctors from starting a private clinic in a desirable location. Next. So mixopathy, no to mixopathy. Quackery is a term which is quite common in the medical fraternity. It is interpreted as layman practicing medicine without medical council registration, without appropriate medical education, formal training, and licensing. These doctors practice diagnosis as well as prescribing medication. Next. Due to lack of established practices, discipline, and correct medical methodologies, patients are at risk of getting incorrect medicine and or diagnosis, which can lead to worsening of the condition or even fatalities in some of the cases. Quackery undermines The family physicians who are practicing the profession with the highest ethical standards. Next. So changes in society's outlook nowadays. Society's outlook is totally changed towards family physician. Previous one. With the increase in awareness of the general population, patients believe that specialists have more advanced understanding of a particular ailment and are approached directly without a referral from family physician. For ailments like diabetes, hypertension, and other diseases, patient approaches consultant. फ्रेंड्स हमने ही उनको बड़े बना दिए है डायबिटीज और हाइपरटेंशन के प्रेशर आते हैं तो हम क्या बोलते हैं कि भाई स्पेशलिस्ट को दिखा दो बड़े डॉक्टर को दिखा दो we have to come out for the comfort zone recently previous slide was of the diabetes we have to learn more in detail about the diabetes hypertension lifestyle modification diseases cancer ailment and provided treatment from our clinic only next cutthroat competition previous one changes in society's outlook cutthroat competition family physicians are now not competing with only our allopathic colleagues but they are competing with IOs half-baked doctors OTC medicine all scheduled drugs they are dispensing from their stall alternative therapy media botanical medicines media advertisements quacks and others. And disheartening is that government is unwilling to prevent quackery, which is really worsening the problem. Next, physician burnout. Family physicians are under increasing pressure due to lack of resources and diminishing workforce. Rising patient demands and expectation combined with inequality in terms of financial compensation may cause them to feel stressed, burnout, anxious, or depressed. Next. So, how to address these issues? Next. Do family physician plays an important role today? I say 100% yes. We are playing important role today in the society. We are the backbone of the society. We are the person of first contact in 70% of the diseases when patient approaches the first. It is important in a country like India because 75% of the healthcare expenditure is shelled out from patient pocket and the fee structure of family physician is affordable to patients of all income level. Next. In addition, we are aware of the socio-economic condition of all patients, which allows to seek the best possible path in terms of prescribing generic versus high-cost drug as well as investigation order. Still, we are enjoying in India a status of friend, philosopher, and guide for families. Next. In addition, the family background, family's past history, and genetics, we are likely to pick it up to 4 generations of the members in the families. So, family doctor is easily accessible, most affordable, always available, and gives continuity of services 24 into 7 into 365 days. Next. We are managing geriatric care. We know that day by day geriatric population is increasing. So chronic illnesses, strokes, heart diseases, asthma, diabetes, cancer are some of the most common chronic and degenerative conditions managed by family physician. And we are providing ongoing and personalized care to patients through some of the most challenging times. Next. Friends, when family physicians enter into practice, their aptitude in the art and science of family practice was lacking. With the advancement in research, newer diagnostic tools, newer medicine, family physicians must update themselves by attending CMEs, lectures, and conferences to keep up to date with latest information. Next. We have next, family practice and evidence-based medicine. Next, present major changes in the treatment of disease have taken place during the last 20 years as a result of research in general practice, along with introduction of the newer technologies. There are three triangles. First, we always give importance to the receiving hand patient. Then doctors have to inform in detail regarding which are the best treatment they are providing. Third is the clinical research. Next, there are a number of myths and rumors regarding the family physician in society. They consider now no more friend, philosopher, and guide. Our services are more expensive. Medicine is costly and have more side effects. Patient is unnecessarily harassed by us. Nursing and hospitals are costly. Other types of treatment cure the disease, while we allopate only treat the symptomatic relief. These above are all the myths which have contributed to patients' growing suspicion about the integrity of the allopathic system of medicine. All these issues require our immediate attention before things spiral out of control, and only good relationship based on mutual needs, regards, and faith is important. Next, when it comes to the question of fees and economics in family physician, new family physician faces a tough competition nowadays with a spiraling escalation in all the basic amenities in life with very high maintenance cost of clinic. The present average charges collected by family physician is grossly inadequate. So, Surat Family Physician Association has prepared a price list in the month of 1st April 2018, and they have distributed to all the members. Next slide, I will show it, and if time permits, we will discuss. And I also request Gujarat State Family Physician Forum to encourage to discuss such an issue and pass directives to introduce uniform charges. Next. Next. This is charges list. Next. So, starting diploma and degree courses in family medicine. Friends, it is now high time to start diploma and degree courses in family medicine. Yesterday, Dr. Raman Kumar also mentioned it, with the help of which family physician can strengthen their basic knowledge for providing best medical services to the patient. Physicians are also urged to attend source courses run by IMA College of General Practitioner, online diploma courses, and other courses to acquaint themselves with the current trends and latest breakthroughs in the field. A family physician can also motivate their patients for adult vaccination, start facilities of teleconsultation, video calling, online consultation, and create facility for payment gateways in their clinic only. This may lead to extra sources of revenue from practice. Next. These are the various courses run by IMS College of General Practitioners. Next. So with the concluding remarks, change is inevitable. There is change ahead. The needs of modern medicine, increasing patient expectations and government demands means that general practice probably faces more accelerated change in the coming years. It may be challenging to question some core values and ask if our current models of practice are fit for purpose, but we cannot hold unquestioningly to structures of the past, but most constantly ask ourselves if we could do better for our patients by keeping up with the times. Next. Thank you. Change is hard at first, messy in the middle, and gorgeous at the end. Thank you. I am thankful to Gujarat State Family Physician Forum and Ahmedabad Family Physician Association for the opportunity given to me today to express my views.
Thank you. Thank you very much, sir.
Thank you, sir.
You have highlighted points very nicely. So there is two things about the burnout. The recent survey has been taken, and unfortunately, the family physicians number is number 3 in that burnout medical fraternity forum, right? And then number two is Dr. J. Jaigal has told me that they are also thinking of starting the diploma and say MD courses in family medicine. So probably Indian Medical Association is taking the step towards these things also. So
Sir, Rajiv Gandhi University is right now only university where diploma and degree courses in family medicine is going on.
now, thank you, sir. Now we are moving to the second lecture. And for that, I will invite Dr. Anil Panse. Please share the screen for his introduction.
Yeah, I'm
Please,
there.
excuse me. Yes. Yeah, Dr. Anil Panse, he is from Pune. He is MD Preventive Medicine, then DNB and FCGP. His international certificate in primary care by Israel. Lecturer at BJMC Pune, Bharat Medical College Pune. He held various posts at FFPI, IMF Pune and Maharashtra State. He is practicing family physician since 41 years, with indoor facilities since 12 years. He has presented many papers at national and state levels, and he is recipient of Lifetime Achievement Award also. So with this small biodata and small CV, I request Dr. Anil Panse to start his presentation. Dr. Anil Panse, please. Dr. Anil bhai, please.
Yeah. Good afternoon.
Please share your screen.
Yeah. Yeah, I'm there.
Okay. You see, please share his screen for the slides. You
Yes.
see?
Sir himself is going to do.
No. I had already.
Okay.
I already sent him.
Sir, I need to check 1 minute, sir.
I already sent you, sir.
So keep the discussion on by the time he shares screen.
Anil bhai?
What should be the password then? I'll have to share it again then.
Tell him the password, Pragnesh.
No password for sharing is required.
No. He has just joined with other laptop.
Acha, okay. Just a minute.
Okay. He's online.
I'm not getting it. Is it a Google Drive?
418962 is the password.
No. He's asking. एमना घरे बात करे sir.
Okay. So you were on. Come on.
Yes. Yes, I am seeing this thing, but I am not being able to share the things.
Admin, please give him right to share his screen if it is not given.
Sir, I have shared Dr. Sir's
Okay,
PPT.
It is showing that. Yeah. Now I am seeing the slides now.
Yeah, okay. You can just go on, sir.
Well, now I am seeing this. My slides are there in front of me. Now
You just start your presentation.
Yeah, no problem. Well, at the outset, I must thank the conference organizers for giving me an opportunity to be a part of this particular August conference. And I have got so many friends over there in your Gujarat Medical Association of Family Physicians. I personally thank Dr. Abhay and Dr. Jayendra Bhai and Dr. There are so many people are there with me, and I had been to Gujarat so many times, and it's pleasure for me to be there again in this particular wonderful conference on family practice. Well, at the outset, I would like to share that this is a unique situation that we are facing these days, because for last so many years we had so many pandemics coming and going, like SARS, bird flu, and all that. And there was quite a good surge of the fear in the minds of the people. There was quite a different type of atmosphere there around, but it faded away and there was nothing remaining behind. But this corona has impacted quite a lot in our day-to-day practice in all walks of life, in all the industrial life, in all the economic life, in the education life, and most importantly in our healthcare sector. And therefore we have got a tremendous impact on our health sector, and in that health sector family practice is not an exception, which has affected wonderfully. I would ask the second slide please. Second
Next.
slide please.
You say next, sir.
Next, yeah. So it was an unprecedented disruption in health industry and had long lasting effect on practice pattern. Here, the change of the attitude of not only doctors but also of the patients is also seen, and therefore it was very difficult for all of us to manage these things, and we had to change quite a lot in all the aspects of our life, in giving a service, in practicing our modality, and even the expectations from the patients. Next. So now, next slide. Next. So even the doctors also believed that there was, a different type of practice now in that. Earlier, you all would agree that the patients used to have the personal contact directly to us, and they wanted that. Actually, they used to say that, आपने हाथ लगाया, आपका मुंह देखा, और हम अच्छे हो गए, तो हम तुम्हारे पास आते जाया करेंगे. So they wanted to visit the family doctor every time. The touch of the doctor was heavenly touch all these days. But now the things have changed. Now the people themselves or the patients themselves, they are saying that, doctor, please don't touch. And well, therefore, the overcrowding, they are now avoiding. They don't want to come to the clinic. They want the treatment on telephone. So the things have changed quite a lot. Even the doctors earlier were believing more in the science along with the symptoms and history. So they used to palpate, they used to auscultate, and then they used to decide their line of action. But now even in these changes, now the doctors have also changed, and they have now therefore given equal importance to symptoms and history. And therefore the norms have changed. The social distancing has changed. And now recently has come up the telemedicine. Next slide. Now, the changes in the clinic state here, the personal protection, and even the clinic pattern has changed. In the clinic, there are certain changes wherein we are ourselves using personal protective equipment. We are using mask, shields, and gloves, and apron, and all that. We have put on screens in between. And also, even to the staff, we have provided screens, the protection devices, and the case paper and paper handling is now reduced. The cash transactions have been reduced. So all these changes have come for the staff. And even for the patients, we are now advocating sanitization, use of masks should be compulsory. And we are keeping them separate distancing in especially morbid and geriatric group, or also for the fever patients. So therefore, we have to manage the sitting arrangements even in the patients in the OPD clinic. And that change is very important. And therefore, the clinic care has become a very important thing. Initial and concurrent sterilization, which was not done properly or in everyday life, but now it has become an essential part of our day-to-day practice. And therefore, these changes are there in our clinic settings also. Next slide. Next one. And the changes in the disease management approach is also there. Now, earlier our focus was there on all the types of modalities or all the types of diseases, but now more interest has been developed in more or less in chronic diseases like diabetes, fever, hypertension, then PU and all that, and with respect to the suspicion of corona. And therefore, that is very important. The next change is also there with corona and related things. So now earlier when we started this particular pandemic came, we were rather confused. Then we came to know what is corona and what is the exact manifestation. Then we started suspecting the patients. Then we started diagnosing them. Then we started treating them by giving them home quarantine treatments. And now we are gone into a phase of the vaccine. And therefore, this is very important. Next one. The next slide. The chronic, next slide, please. Next slide, please. The promotion of the domiciliary management is now there from our side itself. Earlier, we were not believing in the patients, and therefore now what we are providing is we are developing our own clinics. Now this is an opportunity to all the family physicians to develop their specialty clinics like diabetic clinic, hypertension clinic, so that you can segregate those comorbid patients and have that different approach to their treatment line. And therefore these changes have come. Now the maximum preventive measures are being taken, as we are advocating now adult vaccination, which was mentioned by somebody earlier. Along with the administration of COVID vaccine, all the details of the COVID vaccine, after its introduction, we have now learned that how it is to be administered, what are the effects, side effects, and all that. So that is also a very important change that has come up in our day-to-day life. Next slide. Next one. Next to now. There was a little touch by my earlier speaker on the economics as such. But the economics, if you find out earlier when it started, this particular corona, when it came, all the things have gone into lockdown, including our clinics. Very few clinics. It has been taken in a survey and told that about only 17% of the family physicians were conducting or continuing in their clinics in the lockdown period. Rest of them, they did not go at all for fear of themselves or for the fear of getting the spread of the disease from their side. And therefore, after the recovery, even that recovery is there, but now that the recovery is not 100%. Therefore, rescheduling of all the consultancy charges, rescheduling of the telemedicine charges are very essential. Patients are at advantage. They are getting their treatment at their home. So the traveling expenses are reduced. Time is saved. And all these can be encashed by the family physicians by making the telemedicine charges told to the patient. And therefore, in that case, the economics is going to be is reviving slowly for family physicians, and that is an added advantage with the change that has come up quite recently. The next slide.
Last minute, sir.
Yeah. So the next slide is the next slide. So now we will be going for the latest addition is the telemedicine. Telemedicine, earlier we were quite skeptical, but now the things have changed. It is growing very fast, being accepted by everybody. The technology advance is very fast. And therefore, we have got all the things that are made very smooth. The digital payment is smooth, the treatment giving is smooth, the contacting is smooth. Next slide. The contacting is smooth. And there are so many advantages. Next slide. Next slide, please. The contacting is smooth. We can have the treatment of the morbid patients at their places, reduce their visits. Great penetration is there. The distance is no limit. Anybody from anywhere can contact you. The earlier people used to take a disadvantage of your availability on telephone, but now you can charge. Now you can give openly and the complete consultation. That has become very important. Documentation is also very easy and perfect. The next one. But there are certain precautions that should be taken while giving the telephonic consultation, where you have to keep the limits. Earlier, the limits of passing the patient to indoor setup was there. Now, this particular limit is also decided, that how far you can give telemedicine or teleconsultation. So this is very important. You should give the validity of the use of your prescription, because it may be used again and again. The consultancy times should be also very well specified. Next one. Next one. And thus, for a family doctor, the changes of safety, making him up to date in the knowledge, the different adjustments of the new entrants are a little bit different. For a young doctor or for established one or for old veterans, the things are different. You have to keep a different time available for your teleconsultation, and you have to take proper precaution of yourself also in this change in atmosphere. Now the corona is not going to go. You have to live with corona, and therefore the basic change now that is there is you have to be with corona. So change your attitude from shake hand culture to namaste cultures, so you can keep the safe distance of the patient. And that is the change that is going to be with us. And I thank again all the next one. I thank again all the organizers, all and tell our friends that be optimistic. The changes are for the better. We will have improved practice line, and therefore will be winning in this particular health infrastructure provision to all our patients. Thank you very much.
Thank you, Dr. Panse Sahib. And as we are running short of time, I straight away invite Dr. Mahmood Merchant, and please share his screen for his introduction. He is MBBS, FCGP, DNB Family Medicine, practicing for last 50 years in Bandra, where West Mumbai, Western suburb, past president of GPA, Greater Bombay, present is scientific convener in GPA, presented many papers in GPA conferences in Mumbai, Surat, even in Ahmedabad also, and Anand, recipients of many prizes in the conferences, and only GP who has taught ECG to 5,000 doctors in Mumbai, Thane and Pune. So with this introduction, I invite Dr. Mahmood Merchant to start his presentation. Please share his screen, his slides.
Thank you, Dr. Disik. Thank you very much for inviting me for such a nice conference. And first of all, I must congratulate AFPAGUJCUN for such a fantastic conference. And what update you have given is really mind-blowing. And what you said about the update. You see, this is the update, what you have given. This is fantastic. I think this is the trailer of the update. But then we have to have the full movie, which we have to learn. And we have called Dr. Tushar Shah about the pulse of medicine. And I can tell you, if you can call to Dr. Tushar Shah for 4 Sundays from 9 to 5, and what medicine he can teach you or teach us, I can tell you nobody can teach. He's a fantastic teacher, and the evidence-based medicine, he will give you the notes. He will bring the the strips of tablets, and he'll put it in front of the groups of four doctors on each table. And I tell you, it is worth calling, and it is worth learning from Dr. Tushar Shah, who is an excellent teacher. We have also a very good teacher in Bombay, and that is Dr. O.P. Kapoor, who is also now available on the YouTube. And what Dr. O.P. Kapoor can teach, I don't think anybody else can be. Such a fantastic teacher, and we can learn from them. And I'm sure people can go on the YouTube and learn from Dr. O.P. Kapoor, who is a fantastic teacher. Anyhow, so let us come. We are, as everybody said, that we are the backbone of the healthcare, and definitely we have to update. And we are not MBA. MBA means mane badu avade, and we are MBBS, member of Beta Beta Society, and we have to relearn, and again relearn. So please put my slide, please. Are you going to put my slide? So what I'm going to say is that we have to really relearn whatever we have learned, and we can do so many things. I am always to update my family friends, family doctors friends, and I'm always for academics. And I always want them to earn more. So how to earn more as well as you update yourself more. And my weakness is cardiology and neurology. So always I start my first slide with the cardiology. My next slide, please. So now I have done the survey, and I found out that only 30 to 40% of the doctors have ECG machine, which is very sad. And I want that every GP should have an ECG machine, and they should learn ECG. And the cost is what? 25,000, 50,000, 1 lakh. Your money is lying in your fixed deposit in the bank, and you are earning 7%. Why not invest that money in the ECG machine? And please learn ECG. And you have fantastic stalwart in your Ahmedabad association who can, the GP can teach the GPs. I have taught so many GPs, and I'm sure one of your senior GPs who is doing ECG, he can teach all the GPs in a group of people, and take at least 4 sessions or 2 hours each or 2 Sundays, and they will learn. And it is really worth learning. And yesterday, when Dr. Dhruv also said that if you don't have an ECG machine, how will you know what is the QT interval? So you had to learn ECG, and because the mortality rate is so high in cardiac, it is number one killer. So we have to learn everything about cardiology and about myocardial infarct. So please, my request to every one of you that 100% of GP should have ECG machine. They should know how to take an ECG, and they should interpret. Please don't buy the computerized machine where they first thing they will write abnormal ECG, and when you give it to the poor patient, and patient they get abnormal and they will get worried. So buy something which does not show that abnormal ECG and all. The comment. Next slide, please. So I have learned my cardiology or the ECG from my next slide, please. My teacher, Dr. KP Mishra, who was a fantastic teacher, and his book. I want everyone to have this book, Primer of ECG, and you will learn everything on ECG on that. But you have to learn practical from the doctor, from the good cardiologist, or from your any senior doctor who is doing ECG who can teach. Next slide, please. Next slide. Next slide. Yeah, this is our Dr. KP Mishra. He is no more. He is my mentor, and what he taught me, and he used to take lectures 3 hours from 9 to 12 in Bombay in Jeslo Hospital. I used to attend those lectures. I must have learned ECG from 10 different cardiologists, but I give my salute to my teachers, and of course there are very good so many other cardiologists who have taught me, and I'm really grateful to them. So next slide, please. Next slide. So I'll show you some now. This is the cardiogram of the anteroseptal infarct. You can see the ST elevation. All of you can see the ST elevation from V1 to V2, V3. So this is anteroseptal infarct. You can diagnose, and you can give immediate treatment by giving the statin, 40 milligram of either rosuvastatin. You can give a soluble aspirin, 300 milligram. You can give clopidogrel, and please shift the patient immediately to a place where there is a thrombolytic therapy and there is a PAVI available. So please do that, because here the time is muscle. Next slide, please. Next slide. Now this is the ECG of the inferior wall infarct. You can see the ST elevation, lead 2, lead 3 AVF. This is the inferior wall infarct, and this is the right coronary block. We have to give the same treatment and shift the patient to the tertiary care or a hospital where the facilities of thrombolytic with the or the PAMI is available. Next please. Next. And this is irregular heartbeat, or when you take an ECG, you see RR interval keep on changing, which we can treat by either, or if it is a recent development, DC shock will revert to normal. But then there are so many drugs available which the cardiologist can teach you. Next, and we have to prevent. If we don't treat atrial fibrillation, we can end up with the stroke. So we have to give the anticoagulant with that. Now, this is the ECG of the supraventricular tachycardia, which we can easily treat in our clinic by giving a carotid sinus massage or Valsalva technique, and it will become normal, and the patient will say, "Arey, doctor sahab, ab to Sai Baba ho gaye." But then there are so many other drugs also available to treat this supraventricular tachycardia by giving adenosine. And what are the indication, contraindication you have to learn from cardiologists, and that's why you have to continue doing your CME. Next slide. Now here is VT. This is a VT is not Victoria terminus. This is a dangerous signal, and we have to act fast. So if you have the cortisone, or if you have the lignocard, the xylocard, you can inject, or you can send the patient immediately to the cardiology ICC unit, and or if you have a DC shock, give a DC shock and it revert to normal. So I think this is a dangerous arrhythmia, which is life-threatening. So we have to learn that. And we have to give drugs for that if required, or we can, yes, next slide. So the cardiology is very important. Before I change over to neurology, see, we have the last 2 weeks ago, we have the cardiac emergency at Jeslo. The doctor was Rahul Chhabria, and he took the cardiac emergency so well. And I tell you that it is available on you can ask for it and you will get it. So that, like for example, if there's a cardiac arrest, how to manage? Cardiac arrest is either asystole or it is a ventricular fibrillation. So when there is, previously we say ABCD. So airway, breathway, circulation, and the drugs. Now the C becomes important. So we have to give cardiac massage. So we have to learn the, cardiac resuscitation therapy. So CRP you should know, and by keep on giving massage by 80 to 100 per minute. And then we have to give adrenaline subcutaneously, intramuscular, whatever, and shift the patient immediately and get the help of others, because when you keep on doing, the cardiac muscle, you get tired, so you need help. And where to give, how to give the CRP, you have to learn. So many other, now the cardiac failure. I think the new drug has come, and early we can treat cardiac failure at home, but if the patient wants to go to hospital, there is no harm. But depending upon the emergency, how bad it is. And now we have so many factors, the drugs are available. So early Vimada is a good drug. There are so many other drugs like the diuretic, we can give beta blocker, but we can treat the patient at home if patient wants to remain at home, and you can, that is patient judgment. Let patient decide. But if patient wants to go to hospital, nothing wrong in that. But the GP can treat cardiac failure. There is no problem with that, and we can do a lot of things at home. But yes, everything should be patient should decide where the patient wants to go. Now about the neurology, because neurology we should not waste time, because here time is the brain, and if you waste time, you will. We don't want anybody to be handicapped. We don't want anybody to get hemiplegic. So early recognition of symptom is essential. As soon as you recognize that somebody is telling slurring of speech, somebody hand is not moving, somebody's face is a little wonky, that person should be immediately sent to the hospital, tertiary care, where they do a CT scan, the perfusion test, and the DSA, and they can open up the artery, because now we are so many here, and they'll say, it is costly. What is cost? Nobody wants somebody to be handicapped. It is better to beg, borrow, and use that money for the treatment rather than remain handicapped for lifetime. So apart from the stroke, you should know everything about it, how to diagnose early and ship them immediately to hospital. The other thing we should learn is movement disorder, Parkinson's disease, myopathies, because we can treat a lot of them. And yes, why not? Having knowledge is very good. And dementia, which I will, there's another slide, because that is the tip of the iceberg, which we have to learn as we are growing old. The dementia are so common, but what is the reversible dementia we should know and we should treat. Next slide, please. Next slide. Now, dermatology, I have not put any slide, because spot diagnosis and treatment. You get a doctor friend, dermatologist, and he will take classes for you with all the slides and the treatment. And there is nothing wrong in learning. And we have so many cases, and how to treat fungal infections, resistant cases. And you have to learn that indication, contraindication, and that is only by having, unless until the dermatology is learned by slide and treatment. And a good teacher make a lot of difference. We have Dr. Ram Malkani, who has taken classes for us so many times, the pigmentary disorder, fungal disorder, scleroderma, the urticaria, you name it. And apart from that, he will give you a small booklet on dermatology with the photograph and the treatment. So we have to learn. You catch hold of a good dermatologist who can teach all of you. And I don't think the 30% of practice is dermatology. So why not learn and treat any derma infection? Yeah, next.
Please speed up,
Next,
sir.
how many minutes, sir?
Only 2.5 minutes.
Oh my God. Anyhow, now the psychiatry, 30% of our practice is psychiatry, and we should learn everything about psychiatry, because we can treat all of them. So next slide, please. Next slide. Next slide. Now the minor surgery. I think a GP should be capable of treating all minor problems. Like, this is a bit low. Very easy to treat. And nothing wrong in treating, because just give local, and just if you make a small gut, pus comes out, treat, patient get all right, give antibiotic. Next slide, next slide, next slide. Now this is CLW. We can still CLW. There is nothing wrong under local anesthesia. Yes, next slide, please. Earlobe repair. We can do earlobe repair. It is very easy to do it. Next slide, please. And the corn. And Dr. Ronak Shah said that we can treat, here I can tell you, without surgery, we can treat corn by just applying salicylic acid, 40% in petroleum jelly at that particular corn, and it comes out very easily. It becomes easy. Next slide, please. And now this what, you can either freeze them or cauterize them or do a laser. But what I can tell you, you can just apply podophyllum to individual corn and they fall off. Next slide, please. Now the urinary bladder catheterization, I've done the survey, and only 10% of the doctors can do urinary catheterization. Please, it is very easy to do it. So please learn that from, how to do catheterization of the urinary bladder when it requires. Next slide. The rice tube, we should be able to put where it is required. Where person is hemiplegic or person can't swallow, that person we can, put the rice tube very easily at home. Yes, next slide, please. Next slide. And the 50% of the doctors have otoscope, but I can tell you only 10% of doctors can do removal of the wax, which is very easy to learn. I have learned my ENT in the ENT hospital. We have the group, and we learned that. So please master yourself how to do otoscopy, how to remove the wax, and even the nasal speaking, how to diagnose various nasal problems. Even the laryngoscopy, the indirect laryngoscopy, you can do it. Next slide, please. Proctoscopy. Nobody does the proctoscopy. I've done the research. Only 10% of the GPs do that. Please, when somebody complains of bleeding per rectum or somebody says there is some swelling, it is our duty to examine the Gateway of India and have a look through proctoscopy, because you maybe that person may be harboring a cancer inside. Next. Now, Fundo, yesterday, Dr. Preeti Kapadia spoke so very well. I think you should catch hold of her and learn fundoscopy. The ophthalmoscope everyone should have. Learn fundoscopy. What is papilledema? What are the other retinopathy diseases? We should learn from a good ophthalmologist. Next slide, please. Next slide. Now, diabetes, already people have talked, and I want the GP should know in and out of diabetes, right from the treatment, when to give, when not to give, what are the symptoms of hypoglycemia, and how to examine the various, the diabetic food should never be neglected, and what exercise to be done, what diet to be done. And I attended one geriatric conference where they said if you are 60, your HbA1c 66.5 allowed. If you are 70, 7 is allowed. If you are 80, HbA1c is allowed. If you are 90, if you see some 90, the HbA1c 9 is allowed. So you have to learn by attending all those conferences. So that gives you a lot of idea. Next slide, please. Next slide. Rheumatology is one brand which is coming up. Please learn everything about rheumatology, because we don't want the deformity of the hand. So as soon as you see little squeezing there, and the person has got and the anti-CCP positive, or there are seronegative positive, you start the steroid, you start the methotrexate, and you start the other disease modifying drug, and patient will be so happy. But you have to do the test, you have to ask for physiotherapy. Next slide, please. Next slide. That is again rheumatology. You have to learn everything on rheumatology, because it is a fast coming subject. Yes. Next slide. Next slide. CKD. Everything. I think we should know how to handle, how to delay the progress of CKD. See, people are taking narel pani. If the potassium is high, you can't tell them, "Arey Baba, you stop the narel pani." And how to reduce even the potassium? You tell them to boil the vegetables and then cook the vegetables. So if you learn everything about the CKD, you can delay the progress and of the CKD. Yes. Next slide, please. Dementia, as I told you, there are reversible dementia and there are irreversible dementia. Dementia is the tip of the iceberg. Reversible, you should know that B12 deficiency can cause dementia. Hypothyroid can cause dementia. Normal pressure hydrocephalus can cause dementia. So the vascular changes in the brain can cause dementia. So all these are treatable. We can treat them. Next. Now, last I have come for the death. Now, many people write in the death certificate, cardiac arrest, cardiac failure, respiratory failure, cerebrovascular accident. Please avoid writing such thing, and you can learn this, how to write death certificate from your local municipal health officer, who can come and teach you for 1 hour how to write a death certificate. We have to die with cardiac arrest. But what is the cause of cardiac arrest? So you write acute myocardial infarct, or is due to what? Ischemic heart disease, all that you have to write. If somebody is suffering from cancer, you write cancer. That is, you can't write respiratory failure. So whatever is the cause, you write, and what is the cause. That is, if you learn this from the local medical officer of the municipality, you can take lecture for 1 hour, but you can learn. Now, cerebrovascular accident, why I have put it here? Because you see, once somebody wrote cerebrovascular accident, and then they went for the burial certificate or the cremation certificate. There the clerk said, "Arey, ये तो accident का case है, medical legal case है." So now he doesn't know that cerebrovascular accident is a stroke brain. So instead of writing CVA, please write cerebral stroke. Yeah. Next slide. So now before I end, I tell you the gynecology also, we have Dr. J. Mehta. Tomorrow he's going to take lecture, and every afternoon he takes for 15 minutes, half an hour. And if you want to know everything about gynecology, amenorrhea, polymenorrhea, how to postpone your period, what is leukorrhea, you please contact Dr. J. Mehta, and he's, apps you can put it. Kai Jala is an app, and every Monday afternoon he takes between 3:15 to 3:45, 4 o'clock. He takes only for half an hour. It is worth learning. And there are so many other things which I have not covered. But yes, Osteoporosis, I think osteoporosis, we should learn everything about osteoporosis, but not from the orthopedic. There are good orthopedic surgeons who can teach, but from rheumatologists and from endocrinologists. And because there are so many orthopedic surgeons, they write 6 injections of erekitol. Please, no, big no. Only 1 injection is enough. So now with that, I will end my talk. Thank you, Dr. Dixit. Thank you.
Thank you. Thank you very much, sir.
Yeah.